floor, from first responders to technology innovators. Different roles, different stories, but one goal: to meet the need for crisis care and overcome the obstacles together. So join in. The Crisis Jam is starting now.
And welcome, everybody. My name is Megan Haupt. I am the chief of staff for the National Association of State Mental Health Program Directors. We are on season 6, episode 253, and we are going to be addressing as a feature presentation how states fund crisis care through CMS and SAMHSA. And we are thrilled to have Dr. Michael Compton, Dr. Leah Pope, and Dr. Amy Watson, otherwise known as LAM, Leah, Amy, and Michael, or it could sound like a legal firm, Compton, Pope, and Watson. However you want to do it, these are great folks, and we are super to have them on. So, all right, let's go to the next slide. Okay, great. So earlier in the Backstage Pass, we saw a video about CIT, and we want to do a sound check for the people on right now that we actually met Dr. Michael Compton through Georgia CIT in 2004. And so what's been your involvement with your local CIT training program? Go ahead and put in the chat what your involvement has been. Let's take a look at that. We do have some folks on that have been involved in local training, so just super admire that. Great. And so here we have the crisisjam.com. This is the website, the entry point for all things Crisis Jam. So it includes on that main page, being able to access past episodes. You can even go to a certain button on the main page if you ever want to be on the hot seat. So you can fill out something related to that. You can also register for the Crisis Summit 4, which is kind of a more closed event, but you can get those past episodes, YouTube videos, and I believe at this point there is a way to see the next 3 episodes that are coming up. So kind of a playlist that will be shown there. Wonderful. Thank you. All right. And there are the YouTube videos. You can also go to 5 Lanes, One Road to Recovery on YouTube. There are lots of ways to get to these. All right. Next slide. I have this terrible. Okay, great. So this news. So let's go to Lydia on the SAMHSA TTAC, and to talk about SAMHSA TTAC and the Policy Academy. So Lydia, are you there?
I am here. Thank you so much for the introduction, and hello everyone. I'm so excited to be here with you this afternoon or this morning, wherever you're joining from. So I'm Lydia Hernai. I'm a behavioral health project manager at Altarum, and I serve as a co-project director for SAMHSA's Crisis Systems Response Training and Technical Assistance Center, which is a mouthful, so we refer to it as the TTAC. If perhaps you're not familiar with the TTAC, SAMHSA developed it to provide training and technical assistance to states, territories, tribes, tribal organizations, and community partners across the 988 system and the broader crisis continuum of care. And our goal is really to provide and support the development of crisis care systems that are integrated, sustainable, and aligned with evidence-based and evidence-informed practices. So we do that in several different ways. One is through individualized training or technical assistance to help programs and organizations strengthen their capacity and achieve their individualized goals. We also do that by organizing and hosting a policy academy. We did this annually for 10 selected teams of states, tribes, and territories. This year, happy to announce that we're doing this in Milwaukee, Wisconsin on March 10th and 11th. And these teams are going to come together to learn from subject matter experts, to connect with peers from the crisis care systems across the country, and work with a dedicated facilitator from the TTAC, who's then going to continue to support them for the rest of the year on achieving their goals. In addition to that, we also host a number of webinars, workshops, and we provide cohort-based learning opportunities through learning collaboratives. I'm going to drop it in the chat, a link to our upcoming webinars, and there are several, and I'm going to invite you to join us as you can. So register for any or all on there. We would love to have you. As you'll see, there's topics including supporting children and youth and families in crisis care, partnering with emergency and first responders, supporting older adults, among others. There's lots of topics that we cover on the TTAC that we provide to the greater crisis continuum, and we would love for you to be a part of it. Check us out and reach out if we can be of any assistance to you. So again, I encourage you to visit our website to learn more about our services. I'm going to drop our email in the chat as well. So if you or your organization could perhaps use our technical assistance services, we welcome you to reach out, and we'll schedule a meeting and just kind of hear about your goals and what you're hoping to accomplish and how we can support you. Thanks so much. It was a pleasure to speak with you. Please reach out if you have any questions.
Lydia, thank you. We will look forward to having more of the TTAC team joining us in weeks to come. So thank you for your leadership and your impact and all the work you guys are doing. Super. And we are now going to go to the hot seat. Notice the crisisjam.shop, crisisjam.shop. So you can get t-shirts and so forth and swag, but the folks that participate on the hot seat get that swag and a code for that. So we have Dr. Chuck and Uncle Mike. Now, my understanding is Uncle Mike, right? Okay. So we are going back to the pit. In the past few episodes, we've been mentioning the pit, and one of the episodes of the pit tackles ED psych boarding. Okay. So Dr. Robbie, who's the main character, done by Noah Wiley, called it the Consolation Prize Package and asked what they'd won for the next 24 hours. Which one did he not mention? This was on one of the episodes. I believe it was like episode something. I never remember the episode number. Episode 8, season 1. That's what it was. Okay. Do you all understand the question? That ED psych boarding called it a consolation prize package. Now, which one did he not mention? This is a sneaky edition. We have lots of other names for sneaky edition, like the devious David question or the unfair sneaky question, but it's a sneaky question edition. Okay. So A, did he not mention bright lights? B, not mention screaming trauma patients? Not mention hard gurneys? Or D, not mention sleep deprivation? So audience, check it out. See what your poll is. All right. So Dr. Chuck and Uncle Mike, what do you guys think? Remember, it's a sneaky question.
I think I've got a ringer, but it puts the pressure on Mike, because I just found out this morning as we were getting ready to do the hot seat that he watches the pit. I do not. I have not seen it yet. So I'm hoping you got some info for me, Mike.
It's killing me, Chuck, because
Okay.
really do watch the pit, and I do remember the consolation prize package. But my God, which one is it specifically that he didn't mention? Oh man, that's making it hard.
What's the sneaky part? Is it more than one that's the not? Because that was the sneaky part for.
You think?
He probably mentioned, part of me wants to say, and this may not be correct, part of me wants to say one of these word combinations. He probably mentioned all four, and one of the word combinations is off. I guarantee you that's probably why it's sneaky.
All right, let's go there. Let's go there. All right, let's check it out. What happened? The correct answer, he said them all.
Ah,
Go, Uncle Mike. That is totally impressive. I'm so impressed. So he mentioned bright lights, screaming trauma patients, hard gurneys, and sleep deprivation. Yes, he went with his gut for sure.
I could tell them what they want another 24
And
hours.
this is
And screaming trauma patients hard.
this is Dr. Robbie talking about it.
Upstairs.
He said it's super fast, right?
Or this.
All right, so we're going to go to over under. And the over under, this is very interesting. Let's take a look at this. So which of you going to be the over under?
Uncle Mike is
Who's
on
gonna-
a roll. He's gonna cut the cookie, and then I'm gonna try to.
All right. Dr. Mike is going to cut the cookie. So this is a quote from Ken Norton, who was with NAMI, New Hampshire, and the quote is, "Emergency department boarding is wrong medically, legally, ethically, morally, and economically." So the question is, let's go to what Crisis Jam episode. All right, I've got a little lag, so everybody hang in there with me. All right. So in which episode of Crisis Jam did this NAMI, New Hampshire quote first appear? Now, let me explain this. YouTube started, sorry, the Crisis Jam episode started to be loaded to YouTube, starting with episode number 35. Okay, we're now on episode 253. So it's one of the episodes between 35 and 253. So which episode do you think Ken Norton said that?
Gosh, and that, to me, that is such a backbone of crisis care. It had to be early. I don't think it would have taken that long for somebody to come up with that. I agree with everything that he said. But I'm not an expert in every episode of Crisis Jam, so it's going to be a guess. And I'm going to cut the cookie, so I'm clearly going to cut it short and give Chuck an advantage. And I'm going to say like episode, I want to say 60.
Ooh. Okay,
60. Okay.
I agree. It is a backbone theme. And so it wouldn't surprise me for it to be early, but it's such a early one. I think I'm gonna go with the over just because statistically, but I really cannot remember which one it was that Ken did that.
All right. All right. So it was episode 35, like the very first one on the range. Can you believe that? I know. So the beauty of it also is that Ken Norton had also pegged the term crisis jam. He pegged that term and it stuck. And that is how we now have crisis jam as that name. So you guys are awesome. You rock. Thank you. Thank you so much. We're going to go to the lead story with Dr. Compton, Dr. Pope, and Dr. Watson on how states fund crisis care through CMS and SAMHSA. Let's turn this over to them. I believe to Dr. Compton first. Go for it.
Thank you for having us. I'm actually going to turn it straight over to Dr. Watson to get us started.
Great. Hi, everybody. It's great to be here. And actually, it was great that we talked about CIT at the start of the hour. Michael, Leah, and I have been doing CIT research for several decades, and we also do non-law enforcement crisis response research. And we're really excited to tell you about the study that we today It was funded by Pew Charitable Trust. And our focus is looking at how states used federal funding mechanisms to expand or enhance crisis services during the 10-year period of 2014 to 2024. And on this slide, you'll see the 9 federal funding streams that we looked at for the study. For the purposes of today, we're just going to focus on 3 of them. The first one being Medicaid state plan amendments, or affectionately known as SPAs. The second one is CMS planning grants for crisis services. And the third one is SAMHSA Mental Health Services Block Grant and Supplemental Funds. So on the next slide, actually, we just want to kind of situate within the Department of Health and Human Services where the Centers for Medicare and Medicaid, or CMS, sits, and then SAMHSA as well. So the CMS and SAMHSA are the 2 agencies with mechanisms that we're talking about today. So during the period that we looked at, 2014 to 2024, there was a lot going on. The COVID-19 pandemic was declared by WHO in March of 2020. Also in the spring of 2020, we had some social upheaval after the killing by police of Daniel Prude in Rochester, New York, and George Floyd in Minneapolis, Minnesota. Following those killings, as well as many others, we really saw the rise of the Black Lives Matter movement and just growing awareness across the country that we really needed to shift crisis responsibility away from police whenever possible and build the crisis response system so that people could have a mental health response. During this period, we also had a number of Olmstead-related lawsuits that prompted states to start building more robust community crisis services. And the Department of Justice Civil Rights Division also was looking at failure to have non-police crisis response services and over-reliance on police as potential ADA violations. Legislatively, during this period, there was also a lot of activity. I know people who attend this crisis jam are probably quite familiar with the legislation that led up to the launch of the 988 Suicide and Crisis Lifeline in July of 2022. Started with the initial National Suicide Hotline Improvement Act in 2018, and then the National Suicide Hotline Designation Act of 2020, which designated 988 as the 3-digit number. It also allowed states to assess a cell phone surcharge to help fund expansion of crisis services. Several pieces of legislation related to the COVID-19 pandemic also provided resources that states could use, some of which for expanding crisis services. We had the CARES Act, which is the Coronavirus Aid, Relief, and Economic Security Act, which is a bit of a mouthful, that was passed in 2020 that provided some relief to states and some funds that could be used for crisis services. Next, we had the Coronavirus Response and Relief Supplemental Appropriations Act. Again, that was in 2020. And then the American Rescue Plan Act, better known as ARPA, that was passed in March of 2021 that provided funding opportunities for states that wanted to submit state plan amendments to expand their crisis services and some expanded reimbursement. So now I'm going to pass it to my colleague Leah Pope, who's going to take us to the next slides.
Great. Good afternoon, everyone. Really nice to see you all and be here. So I'm going to start by talking about how state plan amendments figure into this equation. And if you look at the American Rescue Plan Act that Amy just mentioned, one of the things that CMS did through that act was to help incentivize the expansion of mobile crisis services. And so the act allowed for a new state Medicaid option that was established for eligible or qualifying community mobile crisis teams. And states that wanted to pursue this would be able to receive an enhanced federal match of up to 85% for Medicaid beneficiaries' mobile crisis response payments over the 5-year period, 2022 to 2027. So ARPA made this available for all states to pursue, but in order to do that, states had to submit what's called a state plan amendment to become eligible to receive that enhanced match. If you're not familiar, all states have a Medicaid state plan describing how the state administers its Medicaid program. And when a state is planning to make a change to its program's policies or operational approach, they have to submit what's called the state plan amendment to describe exactly what they're asking to change and how they're going to do it. It's a very detailed process. So if we look at the state plans on the next slide, our analysis, if we can just move to the next slide. Great, thank you. So we searched state plan amendments in the federal database using a specific methodology over the 2014 to 2024 period and made decisions about whether they were relevant or not as a team. So I'm going to highlight here first an enormously high number of state plan amendments submitted during this time. So over 10,000, almost 11,000 state plan amendments that we had to go through that were submitted across the 50 states during this 11-year period. And so we obviously needed to come up with a solid methodology for figuring out which of these state plan amendments are relevant to crisis services and which have nothing to do with crisis services. So we did a first cut where we did a keyword search using keywords related to crisis services. And we were able to use that keyword search to get the 10,951 SPAs down to 888 for our team to review. And then we did an in-depth analysis review of those 888 to really decide, does the word just crisis appear and it's not really relevant to this project, or is this a state plan amendment that is core to enhancing or expanding crisis services? We ultimately found that of those nearly 11,000, there were 115 that we deemed relevant. So 115 different state plan amendments that really are at their core about expanding or enhancing crisis services across the states. And you can see here that states really vary in terms of how frequently they submit state plan amendments, meaning how often they're changing their state Medicaid plan. Obviously, you see California high at 421, Alabama has 110. So, you know, how often they're using this as an approach. And then you can see on the slide that in terms of the ones that were deemed relevant to crisis services during this period, 12 states had 0 state plan amendments related to crisis services, up to New York having 10 state plan amendments related to crisis services. So it really varies in terms of how states are leveraging this mechanism to change their crisis services landscape. The last thing I'll say before going to that next slide, you can keep it there for now, is just that we classified the state plan amendments into low, medium, and high impact. And that was really our effort to get a handle on sort of the potential effects on crisis services in the particular state. So just as one example, something we deemed low impact was many states submitted state plan amendments where they would increase reimbursement rates in response to COVID-19. And that was something that would, you know, impact services across the board, not specific to crisis services. And so we thought that that was something that may have an impact on crisis services, but probably low impact because it's influencing services across the board, versus something high impact, adding mobile crisis as a reimbursable service for the first time. On this slide, just want to mention the next mechanism for enhancing and expanding crisis services, which are CMS planning grants. So knowing that state plan amendments and improving crisis services takes a lot of work at the state level, CMS gave 20 state Medicaid agencies 1-year planning grants in 2021 as part of ARPA. to really expand their ability to offer community-based mobile crisis services. These grants enabled states to assess the needs of their communities, to prepare for implementation, to look at what they would need for training of teams, and also pursue technical support related to actually developing a state plan amendment. And the idea was that these planning grants would enable states to then submit that state plan amendment. So they allocated $15 million with an average of $750,000 per state. But there was a range. So in states like Oklahoma and Utah, two of the states that received the planning grants, they received about $380,000. And then other states received much more. So Alabama and Vermont received around $950,000. And on the next slide, you'll see that the states that received these grants, so again, 20 states across the country, states applied for them. As of our analysis this fall, 14 of the 20 states who had these planning grants had submitted and had approved state plan amendments related to reimbursement of mobile crisis. So the idea being that 14 of those states really were able to leverage those planning grants to turn it into a now approved state plan amendment. I'm going to turn it over to Michael now.
Thank you, Leah, and thank you, Amy. And thank you all for having us on Crisis Jam. I just want to mention that our full report is some 183 pages. You're welcome to take a look at it. Leah is going to put it in the chat so that you have the PDF. Please share it with anyone who might be interested in this topic of funding of crisis services. And again, we thank the Pew Charitable Trust for supporting this work. I'm just going to say a couple of minutes worth on the SAMHSA Mental Health Services Block Grant. You know, every year, every state gets a block grant from SAMHSA. Not less than 10% of it is used for services for children. No more than 5% of it is used to administer the block grant by the state mental health agency. There's, for several years now, been a 10% set aside for early intervention services like coordinated specialty care for first episode psychosis. And thanks to the CRRSAA of 2021, there is now a 5% set aside for evidence-based crisis systems. So 5% of the block grant is set aside each year since 21 for crisis services. Now, the next slide shows our calculations about the mental health services block grant. You might be wondering, well, just how big is the block grant to each state from SAMHSA each year? Based on our calculations, the block grant accounts for about 0.4 to 5.3% of a state mental health authority's expenditures per year. The average across the 50 states in DC is about 1.7. So about 1.7% on average of a state mental health agency's expenditures is covered by the block grant. So it's an important funding stream, but it's a relatively small funding stream in the grand scheme of things. Now, when we think about the 5% set aside, based on our calculations, it represents about 0.04 to 0.4% of a state mental health agency expenditures, and the average across the 50 states in DC is about 0.14%. So yay, we're happy to have the 5% crisis services set aside, but it's really a drop in the bucket when it comes to crisis services. This table is a snapshot from our big report. Again, we encourage you to take a look at the report. This just lists 11 states here, and the red boxes sort of highlight a comparison between two states. I just picked Arkansas and California. On average, the block grant for Arkansas each year over 2014 to 2024, excluding 2021, which was a strange year, on average, Arkansas gets about $6 million a year. California gets about $92 million a year. In 2021, there was a huge increase in the block grant, and then it normalized again in 2022. On average, Arkansas gets about 1% of all block grant funds. California gets about 13% of all block grant funds. You can take a look at your own state. These allocations are based on a formula. But in terms of the crisis 5% set aside, on average, a state like Arkansas gets about $450,000 a year. A big state like California gets about $7 million a year. That's the magnitude of the 5% crisis set aside. And so in our report, one of our recommendations is really that we need even more funding for crisis services in terms of the set aside. Just to wrap up here, we just want to mention what some of our recommendations in the report look like. We give recommendations for local providers. Please take a look at those. We give recommendations for state government, for the federal government. And then at the end of the report, we talk about some things that we initially didn't set out to cover in our analysis of these 9 different federal funding opportunities, but we felt were really important. So some of these are things like Medicare and private health insurance having a role to play in funding crisis services. We need more attention on crisis transportation as an important element of crisis services. There needs to be an explicit commitment to racial equity. We probably need more innovations when it comes to youth crisis services. We probably need more innovations for rural and remote areas. Obviously, we need a competent and well-trained crisis workforce. And then finally, at the very, very end of this 183-page report, which does have an executive summary that you can read if you don't want to read the whole thing, we mentioned that investments across the behavioral health continuum of care will ultimately reduce the need for crisis services as we move forward. So thank you all again for having us, and I will turn it back over to Megan.
Fantastic information. Thank you so very much. And so let's go to our roundtable. You all are fantastic. What a great resource you all have done. And yes, we will distribute far and wide the paper. And let's go to Stephanie Pasternak as well as Dr. Margie. Let's start with Stephanie, who's Director of State Affairs for NAMI National, to give your reflections on this, Stephanie.
Yeah, happy to. Thanks, Megan. And I think I want to start by saying thank you so much to Doctors Watson, Pope, and Compton for this incredible paper. There are so many ways the federal government has supported crisis services, but, for us, as advocates and then also for policymakers to have that all in one document is so helpful. I think what struck me in the presentation in the paper was really the variation in how much some states are taking advantage of federal opportunities, particularly in Medicaid, as we saw with Dr. Pope walking through those differences in Medicaid waiver numbers. And just I see that as a huge opportunity for states that may not be drawing down all the federal Medicaid support that they could be. And that's where those planning grants too that you emphasize come in, because there are a lot of solutions that are out there, but it really takes time for system stakeholders to get around the table and actually hash out how are they going to pursue some of those solutions. And I also think there's a lot being said in what you weren't able to touch on too much, but I know it is in the paper, which is how much Medicare and commercial payers are paying. And since the answer to that is not a lot, I see that as kind of the next frontier in the advocacy space on this.
Stephanie, thank you very much for your reflections on that. And Dr. Balfour, what are your reflections? What's your experiences on this?
Yeah, I mean, this is just such like a tour de force of really documenting what states are doing. And one thing that I've always, one of the frustrations with crisis has been that up until recently, it kind of flew under the federal radar, was very much a thing of the states. But there's also a flip side to that, especially with the Medicaid waiver programs, where you kind of have like 50 experiments on how to do things differently. And I've always thought that we should do more in comparing what our states are doing with the waivers so that, you can learn like what are best practices for, different types of populations and states. This also illustrates something else where I've always said, which is, Medicaid is such an important part. They asked Willie Sutton, why does he rob banks? And he said, that's where the money is. And, this really illustrates that, crisis services really, like a state like Arizona, which has been doing this for a long time, was able to do what it did because it built its crisis system on the backbone of Medicaid. And still you have in many places where whoever's administering the block grants and whoever's administering Medicaid, aren't necessarily coordinated and talking to each other. I think that's changing. But being able to leverage all of those funding sources, I think, is extremely important. And if you look at the updated SAMHSA guidelines and in the, the roadmap to the ideal crisis system report, one thing we talk about in there is the importance of having some sort of accountable entity, some sort of conductor, that's coordinating all the different pieces. And the funding structure really can support that. And so I think another important thing to look at is that question of, okay, well, who's administering Medicaid? Who's administering, what, the states are doing with the block grants? And, do you have like 10 different Medicaid MCOs and then, a county here? Well, who's in charge of coordinating that versus, some other models where those different funding streams are braided together? But yeah, this is great. And I'm looking forward to seeing, what you do, in your next iterations of following some of these threads.
Yeah, no, thank you. Thank you so much to you both. And I imagine you have to have a really good relationship with your Medicaid agency. And I know in Arizona, it's almost the same person or structured as the same person, but there are states that it's not the same person. So how do you really develop that relationship and have that good relationship to really move forward as well? Yeah. No, thank you both so much. And let's move to the next aspect. Wonderful. Let's go to the briefing room with SAMHSA and have Dr. Richard McKeon up.
Thank you. Thank you so much. Great to be with you as always. Give you a brief briefing from SAMHSA. One of the things that I've mentioned over the last couple of crisis jams was reminding folks that the current notice of funding opportunity for the Lifeline 988 administrator is currently available. That will be closing in just a couple of weeks. So if anyone's considering it, that the time available is starting to get shorter. So obviously we will continue to keep folks on the jam apprised, not only of when the funding opportunity closes, but then when we ultimately make an award for the network administrator. We will definitely be sharing that with you just as soon as we possibly can. Also, again, please be on the lookout for the other 3 grant opportunities we are anticipating this year from the 988 office, including the state and territorial grant program, the tribal grant program, and the crisis center follow-up grant program. And I would be remiss if I did not also recommend that you be alert to some of the superb programs in the suicide prevention branch that are on the forecast for SAMHSA for this fiscal year, in terms of including the Garrett Lee Smith state and tribal youth suicide prevention grants, which have documented evidence of reducing youth suicide in counties implementing those activities. Our Zero Suicide Grant Program, So there's a lot of really important funding opportunities that'll be coming out. Also wanted to mention, I spent this morning and yesterday in an event put on by our service member veterans, the Family TA Center. This is a three-way meeting. It's held here at SAMHSA between the Veterans Administration, SAMHSA, and the Department of Defense. And with the focus being on suicide risk during the transitional period when a service member is leaving the military and transitioning to veterans status. Important piece of work there. And it was great hearing earlier in the jam a report out from our crisis TTAC, which is doing great work. And in fact, yesterday I was on a webinar that was focused on 988 and 911, in particular, highlighting the 988, 911 risk and liability toolkit. But again, that coordination between 988 and 911 is just absolutely vital moving forward. So I will stop there and we can punt it back.
Wonderful. Thank you, Dr. McKeon. Just really appreciate your update. And let's go to NASHBID. And we have Kirsten Baronio, who is a senior advisor at NASHBID. Kirsten, come on up.
Hi there. Thanks, Megan. Nice to join you all this afternoon or morning, depending on where you are. Yeah, I just would like to add my appreciation for the report by Dr. Compton and colleagues. I think that it provides a really useful compendium with lots of detail on how states have used the various federal funding streams to increase availability of crisis services. A lot of that, information is publicly available, but to have it all in one place is super helpful. If you look at the report itself, it goes, has summaries of what each state had included in their state plan amendments, from mobile to crisis receiving and stabilization programs, how they've used 1915C authorities, particularly for youth, with providing improved access to crisis stabilization services specialized for youth and families. It would be helpful to see a little more on the 1915I authorities, maybe a research project for another time. And then the 1115 authority, obviously being very important, and really providing some nice summaries of how states have used that authority to improve access to a full continuum of crisis services, including, how CMS has really used that authority to incentivize states to build out their crisis continuums as part of a Section 1115 demonstrations focused on people with serious mental illness in particular. At NASHBID, we regularly meet with mental health commissioners, state leaders on behavioral health, and provide technical assistance on a wide range of issues, including, how to think about financing crisis stabilization services. And this, paper will be extremely helpful for us in those efforts, obviously highlighting the key role of Medicaid, but also how the block grants and other grant funding can really help supplement and enhance that, sustained Medicaid financing. I think what's also really interesting in the report is how important I think CCBHCs are going to be for the future of, how states are thinking about crisis stabilization. Obviously, there's ongoing, grant funding related to CCBHCs and the Medicaid demonstration. And, those are key funding streams. Crisis is a required component of the services that CCBHCs are required to provide access to. And NASHBID is very involved currently with, some of those efforts at the state level. We have a project with the National Council for Mental Wellbeing and McKinsey to work with some states on really building out their crisis continuums, and thinking about all of the issues that are highlighted in this report. So just one last comment, the importance of data collection. I think, as we go forward in this new era of really constrained budgets at the state level, cuts in Medicaid going into effect next year and already happening, will be really important to be able to demonstrate the value proposition of some of this work on the crisis, particularly around crisis stabilization services. I think there's a great story to tell there, but we really do need to think about how to build out data capabilities, and things like the block grant and other grant funding, like the Rural Health Transformation Grants, for example, can be really helpful in that regard. So those are my thoughts. I will turn it back over to Megan.
Kirsten, thank you. And so just wanted to see also what your take was on private payer. Do you have any thoughts on that?
Well, I agree that it is a big gap. I will say there are a number of states, though, that have really taken the lead in requiring coverage for these kinds of services. So that's, I think, also some of those details, if I recall correctly, are in that report. California, Washington State come to mind. We know Michigan has done some work in this area as well. So I do think that will be really critical too, as we see these Medicaid cuts going into effect. We expect, Congressional Budget Office, for example, anticipates that will result in a lot of people losing coverage. And so that will inevitably put stress on the public behavioral health systems, including crisis response services. So it will be really important to think about what are the other funding streams, and commercial insurance. A lot of, these conditions do not just affect people on Medicaid or Medicare for that matter. So, really making sure that people who are enrolled in private insurance will be critical going forward, for fairness, and also just to help with some of those financing issues.
Mm-hmm. Kirsten, thank you very much for your reflections. Kirsten has just been a goldmine of expertise, and so thank you for your leadership and your expertise for all of us. Thank you. Let's go to Voices in Crisis Care. Now, this is the second in the series. We're going to have Dr. Balfour up, and we're going to be going back to the pit. A couple weeks ago, we were talking about some of these issues. I'm going to turn it over to you, Dr. Margie, to kind of set the stage for this.
Sure. And yeah, I feel like HBO should be paying us for promoting their show so much. But a few weeks ago, I was on the trivia question, and one of the issues that came up was a suicidal crisis for an attending physician, and sort of like that show sort of shows a day in the life of an ED physician where every hour is a shift. And in the first episode, you've got the off-going night doc on the other side of that railing there. And not to give you too many spoilers, but at the end of the season, their positions are reversed. And so, in preparing for doing the trivia thing a few weeks ago, I was just looking up some stats on physician suicide in case it came up in the discussion. And and physicians are more likely to die by suicide. And you talk about workforce a lot, and so the average med school class is about 150 per year who graduate. And if you look at physician, I was kind of shocked to see the actual number, but there's 300 to 400 physicians die by suicide per year. So if we're doing all of this to try to, we're talking about workforce shortages. If you were to reduce physician suicides by half, that's basically building a medical school. So what can we do? like I said, physician suicides, we're 2 to 3 times higher than the general population as our risk, especially in females with emergency medicine and psychiatry up in the top, 5. And it's related to burnout, but there's research that's trying to untangle that and it's showing that burnout and depression are two different distinct entities that, worsen each other, but the depression risk is what is driving the suicide risk. And we talk about what do we do about it. We talk about in our patients, we talk about social determinants or social drivers of health. Well, in medicine and healthcare, not just for physicians, but healthcare in general, it's like we have institutional determinants, kind of, where, and one big piece of that is just the stigma and the negative consequences that can come from asking for help, which discourages many. And so I put a couple links in the chat. The first is the Dr. Lorna Breen Foundation, where she was an emergency medicine physician, very much like in the pit, was traumatized by working in the midst of the pandemic and died by suicide. And she was afraid to ask for help because she was afraid what it would do to her job, what it would do to her license. And, if there's any physicians on the crisis jam, when you apply for your state license, there's all these, questions about have you ever received any mental health care? And, I myself have been treated for depression over the years. And, I remember sitting in front of that question, trying to do mental gymnastics to, be able to answer no to it. And so there's been a movement to get rid of those things, not only at the state licensing level, but if you're running an organization, you're credentialing for your physicians and other professionals too. The Lorna Breen Foundation is looking at all of healthcare workers. They had a law passed, the Lorna Breen Act, that put some money, and Congress reappropriated it a couple years ago, to put some money into some evidence-based practices. Their website there has resources for organizations to look at their own culture and their own, rules around this, as well as ways to advocate. And then there's also the link to the AMA, has really great info on preventing physician suicide. But a lot of these things are applicable to all healthcare workers, not just physicians. But thanks for giving me a few minutes to talk about that.
Yeah, Dr. Balfour, that's absolutely incredible. And it reminds me of how what veterans talk about with the military, that they have to be the strong ones. And if they're asked, they could lose their rank, they could be dishonored, all of those consequences. And it reminds me of, it's almost a us, them. We have to be strong, but we're helping people who aren't in some way. And, we're all humans. So I really appreciate what you're sharing. Thank you. And thank you for sharing your own experience. Okay, let's go to behavioral health links. John Draper, to talk about policy to payment to the person, or
Thank
policy
you,
to
Megan.
payment to the person. There we
That's
go.
pretty good. I love that earlier presentation on state funding. So one thing we all know on the JAM is that getting crisis funding approved is a huge win, and it should be celebrated. But what happens after the funding shows up is where crisis systems either really start to work or quietly start to struggle. Now, no matter the state, the funding stream can look different, as we just saw in the outstanding report earlier, but the challenges that follow can often be tougher than getting the money. Very quickly, the questions are going to start. Are we using the money the way we should? And we said we would? Can we explain it clearly to legislators or Medicaid? Are we seeing better outcomes, not just more activity? And this goes to Kirsten's point in her segment when she mentioned the importance of data. Policy decisions often move faster than operations and data can catch up. And the tension shows up in a specific moment, like a budget hearing or a renewal request, or the hard question, why don't you walk me through what actually happens after someone calls and why this investment is working? And that's where even strong systems can look shaky, not because the care isn't happening, but because their story isn't clear. What we've learned across states is that people aren't only asking for more technology. They're asking, do we understand what happens to people after they enter the crisis system? Can we show how call centers and mobile crisis response, stabilization, and follow-up all connect? And can we answer the hard questions about scrambling for the data to do so? It's not about bells and whistles, it's about clarity. One caveat really keeps coming up. If you can't trace a crisis dollar to a real person, a real response, and a real outcome, that funding could become fragile. And by outcomes, I don't mean volume. I mean, is the person safer? Is their distress reduced? Were they connected to the right care? Did they remain stable over time? I love what Richard McKeon mentioned in the last episode about measuring time to empathy. That's a good process measure for getting to another outcome. Did the person feel cared for? Many states report diversion rates, avoiding unnecessary ER visits or law enforcement encounters for the clients we serve, and that matters. But diversion tells us what didn't happen. Person-centered care asks what did happen. Did someone feel safer, supported, and connected? So here's my suggestion. Before the next dollar is spent, ask 3 questions from the perspective of the people in the crisis situation. Can you explain what happens to me end to end? Can you show how your response helped me feel safer over time? And can you demonstrate that without bearing staff and reporting? Now, if the answer is not yet, that's not failure. It's the work that comes after the funding. So yes, strong funding gets crisis care started, and hallelujah to that. The real measure of success isn't how fast we spend the money. It's whether a year from now we can prove that real people are safer because we did. Megan.
John, thank you so much. And if anybody can talk about empathy, it's you. You are one of the most empathic people I know, knowledgeable people I know, and just really appreciate everything you bring to the field and to individuals. I mean, gosh, you talk to John Draper and you feel like you're the only one in the room. So, thank you.
Thank you.
Yeah, great. So let's move it to Kristen Ellis. Take us home.
Sure. Thanks so much. I agree with you. John is a good person to talk to if you want to hear about empathy, and he could be talking about funding. You talk about software and you feel like you're hearing a bedtime story. It's like, oh, wow, I just like your approach to everything. Thanks so much. It was a great conversation. I don't know about you all. I was really bought into the legal firm idea that doctors Compton, Watson, and Pope should probably start. It was a little bit of a joke we had last night in our pre meeting. We thought it was real fun. But yeah, thank you so much for your presentation on how states are funding crisis care through CMS and SAMHSA. Somebody like myself who started in this industry, in crisis facilities, working as a therapist, I always wondered, how do these things get funded? So it was really exciting to hear the other side of it. I just really appreciated the not just theory, but showing how funding can actually move from policy to practice and what makes things sustainable, because these things are really important. Thanks, John, to Behavioral Health for being one of our sponsors. We're always grateful for those partners to make space for these conversations week after week. Speaking of big moments, on your screen, you see Crisis Now 4 is coming this July, and it's shaping up to be something special. We just had to turn that down a little, otherwise you don't get to hear me. We're really excited for all those growing sponsors you see on your screen. Benchmark Human Services is a gold sponsor. Magellan is one of our lunch sponsors. Solari as a bronze sponsor. Centerstone, Lions for Life. So many incredible people helping us make this happen in DC in July, between critical debates, fireside chats, lived experience talks. DC in July is going to be humid, but it's going to be packed with important voices, bold ideas. You're going to want to be in the room where it happens. I saw in the chat, can the agenda be sent out? We are actively getting that on the website, hopefully this week or next week. I'm actually just commented on a mock-up on how we want that to look. So it's really accessible for everybody on their phone while they're at the event. So yeah, please stay tuned. It will be there really soon. Looking ahead to next week, do you hear that? It sounds like Siri. Next week, we'll be joined by Dr. Tom Gruber, one of the creators of Siri, if you can believe it, exploring the ethical frontier of AI, a conversation that feels especially timely right now. I know Siri was, one of the originals. Maybe there's some of the things she can teach us about how to move forward. I'm really looking forward to that conversation with Tom Gruber, who's actually going to be moderated by Dr. John Draper. So it'll be a conversation. 2 weeks out, we'll feature Susan Lang from AHP alongside Dr. Miriam Delphin-Rittman from our headliner sponsor, focusing on what it really takes to build and sustain the behavioral health workforce. That's one of their specialties. It's actually For the person that asked about the agenda, we might be hinting at some of that at Crisis No. 4. That might be something we're working on together. 3 weeks from now, we're also going to dig into the true cost of behavioral health care with Dr. Margie Balfour. We get to have a little more of her. It'll be more than back of the napkin math than her other segments. And Matt Miller unpacking what systems are going to pay, what's often overlooked, and what sustainability truly means. And then a heads up, we love our debates. March 18th, Debate 11 is coming, tackling whether mobile crisis teams should go into the community in pairs, featuring Megan Gleason and Dr. Ken Minkoff. Thank you, everybody, for being part of the Jam today. Thanks for watching. Be sure to tune in, log on, join the movement, and we will see you next week.